We're going to start in as soon as everyone kind of sits down. So, but this is pretty.
Yeah.
Okay, go before we start. Hi, everyone, and welcome back. We're just back from lunch. Our apologies, we're running a little bit behind, but that's because we've had such incredible engagement from both online and here in person here at the conference. So I hope everyone had something to eat and enjoyed the lunch. Thanks again to St. Michael's Hospital for that. So we come to a point in our program that is unfortunately an all too often occurrence when dealing with stomach cancer. And this year is no different. We have lost many friends, many family members, young, old, and so we just wanted to honor their lives, and so we've just put together just a little something to honor those that we've lost. So. So the work we do in many ways is so that we don't have so many of those going forward. Our next presenter is Dr. Christine Brezden Masley. I'm not sure what I can say about Christine. She has been our mentor right from the get-go. I don't think my gut feeling would have started if it wasn't for Christine. She was my oncologist and basically said that the way I was going to get over dealing with all the stuff that I was dealing with stomach cancer was for me to do something. And so this is what I did, and this is why Katy and I do what we do. Christine is a medical oncologist, the director of the Marvell Koffler Breast Center at Mount Sinai Hospital, and the medical director of cancer program for Sinai Health System in Toronto. She obtained her PhD in medical biophysics and her medical degree from the University of Toronto. I could go on, but I'm just going to say Christine.
Thank you very much. Thank you for the kind invitation to speak today. Something that's very, dear to my heart. And as I was saying over lunch, this is one of my biggest beefs, is not for the pun, but trying to get iron into our patients. So I'm going to be spending a little bit of time in terms of, sorry, oops, did I just do something wrong? Sorry, there, I got it. These are my disclosures. So you've heard a lot about stomach cancer. I've kind of stole this slide a little bit from Natalie Coburn, who was previously on the panel. We do recognize that over the last year, and we don't understand necessarily why, but there has been a bit of an increase from 3,500 cases to 4,100 cases of gastric cancer in Canada. So we're still trying to figure out why, whether or not it's a recording issue or whether it's a true issue that there are 600 new cases. And as you can see, Ontario, Quebec, and BC are really the highest incidence. It's probably because of the populations are the highest in terms of incidence of gastric cancer. And then you can see that there's also a 70-75% mortality with this diagnosis. So we do have to do a lot better in terms of treating our patients, diagnosing our patients, and as you've heard, clinical trials is really moving our opportunity to move research and treatment forward for this disease. You know, supportive care, what is supportive care for our patients? I'm a medical oncologist. I treat breast cancer and GI cancer. The GI cancers are colorectal and gastric. I treat a lot of gastric cancer patients. I have over the last 15 years. But I don't do it alone. We have multidisciplinary groups. You heard from Denise earlier today, who I've worked with for 10 years before I moved to Mount Sinai Hospital here at St. Mike's. So nutrition is very key. We work in teams. We work with our surgeons. I work with our surgeons, the dietitian, the pharmacist, the nurses. So we're a whole team. We're clinical trials people. We're a whole team that come together to really discuss and treat our patients. And we also have, obviously, drug access navigators who help us try to get drugs for our patients, one of them being iron, which I will talk about. Obviously, psychiatry, palliative care, and I apologize, I did not put spiritual care up here because spiritual care is a big part of our team as well. I will focus on iron deficiency and why is that so important in this population in our gastric cancer patients. And you've already heard a great presentation about nutrition as well. So you've also heard earlier that Asia has predominantly the biggest population of stomach cancer diagnoses. They've gotten very good at surgery, they've gotten very good at outcomes. So you can see a lot of data that I'm going to present to you from Asia. So what is iron deficiency? Why is it important? Well, your iron is absorbed just outside of your stomach in a part of the intestine called the duodenum. And that's where the majority of your iron is absorbed. And you can imagine if you have gastric cancer and you have already an abnormal absorption in the stomach, the ability of you to absorb iron is very, very low. And it is almost non-existent once you actually have your stomach removed. So if you have a total gastrectomy and you remove your stomach, and you actually then bypass your duodenum, this part, this little 12 inches, that's probably called duodenum, 12 inches of this small intestine actually gets cut out as well when you have your total gastrectomy. And so you aren't able to actually absorb oral iron as efficiently and as well. And so it's very common for our patients to be iron deficient. And they're iron deficient at diagnosis because these tumors bleed, and you're bleeding out. You're depleting the iron, so you're depleting the iron in your body in the stores. And so you're not even able to make new red blood cells, and that's why you're anemic. It's low red blood cells. And so this was basically one study, and I'll show you a couple of these studies, that looked at 161 gastric cancer patients who were curative, and they looked at iron deficiency anemia at 3 months. And they also looked at iron deficiency anemia at 4 years. And as you can see, early stage patients who had stomach surgery is that the iron deficiency anemia, not just iron deficiency, but anemia actually increased significantly with time. And that's something that we're seeing in our patients. This was higher in women, so higher in females, and obviously higher with total gastrectomy because, as I mentioned, you've lost that important organ where you can actually absorb. And this is just showing you a graph here showing the incidence on that y-axis, and just showing you that as time goes on at 4 years is that you see the increase in iron deficiency, and the bottom line there is vitamin B12 deficiency. So you know vitamin B12, and you all probably get vitamin B12 shots, but are you actually getting proper iron repletion? And so B12 is very important. It's important for red blood cell development, also for your nerves, it's very important. But iron is also important for a lot of your enzymes in your body, not only for the development of red blood cells, but also the machinery. And people will talk about being fatigued and just feeling unwell, and when they get that iron repleted intravenously, they just feel significantly better. So this was another also study looking at anemia after gastrectomy in our long-term survivors with stomach cancer. And this is kind of a retrospective cohort study. And this is another Korean study that looked at 5 years from January 2009 to December 2014. Small number of patients, 385, and you have thousands and thousands of patients typically. And they looked at 5-year survival post-gastrectomy. And once again, you can see that the anemia increases, the iron deficiency anemia increases significantly in our patients who have been cured, who've had a total gastrectomy. So we're losing the opportunity to really treat our patients appropriately. And if you can't take a pill, if you can't take oral iron, and you know if you're ever going to take oral iron, that's if you have a functioning stomach, you have to take it with vitamin C. It has to be taken in an acidic environment. You just can't take iron on its own. It has to be taken in an acidic environment. And 1 pill a day usually is sufficient. But with intravenous iron, you get that load immediately, intravenously, through the vein, and patients do very well. And now we have the ability to do it over an hour. So it's quite effective. So once again, just showing you that this is a real problem and we really need to address it, especially me as a medical oncologist, because guess what I do? I give a lot of chemotherapy. And I'll show you some new data talking about chemotherapy-induced anemia. And if patients are already iron deficient, I'm in a lot of trouble with my patients because I'm going to bring down the red blood cells with chemotherapy, and they have no opportunity to rebuild those iron stores. They have no opportunity to rebuild those red blood cells, and the fatigue just continues and the anemia just continues. And we've seen that in all of our clinical trials that have demonstrated both anemia and fatigue in myelosuppressive chemotherapy. So another one, just showing you again, post-gastrectomy anemia in early-stage stomach cancer patients. This was 566 patients with gastric cancer. Once again, just showing you kind of the demographics of this population. But when you look at the population, 42%, so a little bit less than half of the patients have experienced iron deficiency anemia. And then when you kind of took a look at their survival, so this is a classic survival curve. I mean, you know, your survival, look at that, stage 1, gastric cancer, 97%. But it would drop down to about 94% in patients who were iron deficient. So whether or not that is causative, whether or not that is a relationship, but certainly that is a trigger for us that we actually are doing harm if we're not repleting iron deficiency in this specific population of gastric cancer patients who have been cured of their disease. And lastly, when you look at the iron deficiency across different tumors, so the question is, well, is it just for stomach cancer patients? Well, if you take a look at all the other tumors out there, pancreatic cancer tends to be, there used to be a lot of iron deficiency, and you think about the pancreas sits very close to the duodenum, and so even though it's more in the back of the body, but when you take a look at stomach cancer patients, you can see that in terms of the anemia and the iron deficiency, they're right together. So it's usually an iron deficiency anemia, not a vitamin B12 anemia, but an iron deficiency anemia. And then when you take a look, this is just total, when you look at the solid tumors and you're looking at a measurement of iron saturation, which is the TSAT, you can just see that as patients go to stage 4 disease, just not gastric cancer, but all types of tumors, as patients get to stage 4 disease, the iron saturation that's low is the iron deficiency, and the anemia increases, as you can see there. The bottom is very important because this is the ECOG status. That tells us what is the performance of our patient. Can the patient perform normally, go to work, do normal function or activities of daily living normally, or do they have to basically be in bed or take a nap, or are they in bed 50% of the time? And so this is just looking at ECOG 0 to 1. ECOG 0 is 0 to 1 is probably most of us in this room because we came in here, we came in, we're able to walk around and eat and do normal things. ECOG 2 to 4 is patients who are sometimes bedridden. So these are patients who are in the hospital. We tend not to treat patients who are ECOG 3 or 4. We don't give them chemotherapy because they're too frail, too weak. And so as you can see, patients who are ECOG 3 and 4, they have way more iron deficiency and way more anemia. This was a study that we did, looked at our patients at St. Mike's. And we looked at 126 stomach cancer patients, and 40%. Now, this is when I had just started, so I wasn't even looking at iron deficiency. And I do it now in every single new GI cancer patient. I will look at their iron levels. But 40% of our patients, even without me looking at it, had iron deficiency anemia in the gastric cancer diagnosis. And half of these patients got a blood transfusion, and that's how we're treating our patients. We're giving blood transfusions. Blood is a very rare commodity, and if we can use our own blood by re-stimulating our own bone marrow through iron repletion, we shouldn't be giving patients blood transfusions. But that is iron we have to pay for, blood we don't pay for within the hospital. And so this was just who these patients were in terms of patients who got chemotherapy, and just really recognizing that we delayed patients getting chemotherapy. We had to dose reduce patients getting chemotherapy. So it did affect how actually we treated our patients. And that's just showing you the parameters, the hemoglobin levels. And as they went with time, patients were more iron deficient. So we have moved forward. There are lots of perioperative strategies. Patients, we have surgeons in the audience. We certainly know that patients have their iron looked at, and now we're trying to give them intravenous iron to optimize them for surgery, because there's a lot of data now to suggest that patients who have iron repletion do a lot better. That is, if their hemoglobin improves, they do a lot better perioperatively. And this was a big Spanish patient blood management strategy for iron deficiency anemia that really looked at about 19 hospitals, over 600 patients. And when you kind of take a look, we're still transfusing, because once again, transfusion is free and easy. So 42% of patients got red blood cell transfusion. They were trying to decrease that. And so they did decrease it with giving this intravenous iron perioperatively. So this certainly does provide that benefit for patients by giving intravenous iron. This is a real problem for our stomach cancer patients. Iron deficiency is a real problem. And as I mentioned earlier, the big reason is malabsorption. So even when patients are getting chemotherapy, we really can't give them oral iron. They're not going to probably absorb it. Plus, it causes a lot of GI side effects in addition to just not being as effective. So I've always pushed forward, probably not prescribe oral iron and move forward to intravenous iron, known as parenteral iron, so that we can increase the iron within a 1-hour infusion, as opposed to trying to take oral iron, and it takes 6 months to achieve the same level of iron saturation. And so why do we do this? Well, we replete iron because we'll improve the anemia, so the hemoglobin will rise. We see that immediately. We see it within a week. we see a 10-gram increase. Improves the quality of life of our patients, which is extremely important. As I said, many iron-containing enzymes within the body. And at the end of the day, as your hemoglobin improves, it's going to improve your fatigue, it's going to improve your cognition, and really ability for us to work together so that you, the patients, can complete their prescribed treatment. That we don't have to dose delay the chemotherapy, that we don't have to dose reduce the chemotherapy, or we don't have to stop the chemotherapy because we're seeing a lot of anemia and patients just aren't doing well because they're too fatigued. There is new data now also. So in addition to having iron deficiency and anemia, as I mentioned, I'm giving chemotherapy, which suppresses the bone marrow where your red blood cells are being formed. And we know that there's chemotherapy-induced anemia. And now there's a new guideline that's going to be coming out that's looking at using erythropoietin-stimulating agents, so such as EPREX, such as Aranasp. These are just a subcutaneous injection, which is a normal hormone, an erythropoietin, which is a normal hormone in the body that stimulates red blood cell formation. And so by repleting iron and using ESAs, we're actually now going to be improving chemotherapy-induced anemia. And, you know, you can't really see this here, but you just see that chemotherapy-induced anemia is a real problem. 83% of our patients will develop this form of anemia. And just really showing you that, you know, how these patients suffer with weakness, shortness of breath, fatigue, ongoing issues, as we already talked about, and that the use of iron as an adjunct to these erythropoietin-stimulating agents, these ESAs, such as EPREX or Aranasp, really associated with a really great benefit in the hemoglobin response, so decreasing that anemia or improving that anemia significantly. So we had a project called Iron Gut, which is being started, and it is a group of individuals. So we worked closely with Michelle Scholzberg, who had Iron Mom here at St. Mike's. It actually was Iron Angel, and Iron Mom was underneath the umbrella of Iron Angel because St. Michael's is the Archangel. So it was Iron Angel, Iron Mom was under that umbrella, and Iron Gut was under that umbrella as well. And I'm moving that, since I moved from St. Mike's to Mount Sinai, I've moved it to Mount Sinai. So really push forward for assessing and using intravenous iron in all our GI oncology patients who are iron deficient. So as I mentioned, moving across, and I've gone across the pretty much Ontario and many other parts of the country is talking about iron deficiency and the importance of iron deficiency and measuring it. So by the time the patient gets to me, yes, they are still iron deficient, even though they've been diagnosed with a gastroenterologist who's discovered a cancer, rapidly moves that patient to see a surgeon, and that surgeon's working up that patient to determine whether or not they're surgically appropriate or not. And sometimes they have already advanced disease, so then they send to medical oncology. And so that does take some time, and sometimes if the anemia is quite significant, they will get a blood transfusion as opposed to starting on or trying to achieve intravenous iron. Many surgeons will try to give intravenous iron and send to hematology to actually have that patient treated appropriately. But this is really moving forward from the gastroenterologist, the surgeon, so really getting everybody involved together to recognize iron deficiency and treat it up front. So our patients don't have to wait for the operating room, that they can get optimized much earlier. And so these are really the two that are currently out there. Monoferric is a new for Canada. It is a new intravenous iron that can be infused over basically 45 minutes. You can infuse up to 1.5 grams. Typically, I infuse 1 gram. Unfortunately, the government does not fund it as of yet, but we're working on that, and hopefully the government will be funding it in Ontario. The older one is the iron sucrose, but as you can imagine, it takes 3 separate visits of 3-hour infusions of Venofer to actually achieve the same 1 gram response. So we do have a newer formulary, monoferric, and certainly we are moving more and more to monoferric to improve iron in our patients. And so what we will be doing is looking at, obviously, is the quick measurements of looking at the iron levels, making sure the hemoglobin, the red blood cells respond appropriately, doing metrics on our patients' quality of life, and whether or not treatment is affected. Do our patients complete all of their systemic therapy, the chemotherapy that, for example, that I will prescribe? And then is there a difference in survival? I showed you that curve in the beginning. Is there a true difference in survival in our patients? And this is going to be a development of a smartphone app that can be used by patients, so it'll be patient-friendly, and also, they can follow your iron, but it's going to be an app developed for patients, but also for gastroenterologists, for surgeons, for us. So just a little bit of a reminder that we should be looking and treating our patients appropriately. And why is this important? So in stomach cancer, this is important. It's important in many other cancers. But this is just showing you that as time increases, we have more and more lines of therapy for our patients with metastatic or advanced stomach cancer. And this is just showing you a time, this is data from the Royal Marsden, that kind of looked at, the blue bar here is first-line therapy. So you can see over time, there's a little bit of a dip, but typically first-line therapy, a lot of patients will get first-line therapy. What about when the disease starts progressing, the tumors become more resistant to that first line of therapy? Well, second-line therapy. Second-line therapy, you can see in time, it's the red bar. It is now increasing. We have better second-line therapies for our metastatic patients. And then the green bar is still quite small. We want to improve that green bar. We have really great treatments for third. We've got great treatments for fourth-line treatment. And we need to get our patients to third-line to fourth-line treatment. Iron will help us achieve that by ensuring that we support our patients and replete that iron to get our patients with their hemoglobin responses. And just showing you here, this last curve is overall survival by lines of therapy. Now you can say, well, if you've got good biology of cancer, I can go to 3-4 lines of treatment. And if I go to 3-4 lines of treatment, I can live much longer. Yes, that's true. This is shown here. We want to get our patients to third to fourth line treatment because who knows? Sometimes there is a treatment that comes across that makes a huge difference. We've seen this in melanoma. We've seen this in lung cancer. So if we start continually to push our lines of therapy, push clinical trials, that can we then find a target? Can we find a target that will change how our gastric cancer patients survive? And so this is just showing you that patients who have had more than 3 lines of treatment, 50% of them are alive almost at 3 years. Now, you think that's not a big number, but that's a start. So if we can get our patients to more than 3 lines of treatment, we really want to see if we can improve that outcome for our patients. We know that our patients will live longer. So to end off with, you've already heard a great presentation about nutrition. This is so important for our patients. Every stomach cancer patient needs to see a dietitian so that their nutrition can be optimized. And it's not only a one-time dietitian, it is a relationship that that patient has with the dietitian to ensure that they're eating properly, especially if they've had a total gastrectomy. And then, as I mentioned, iron deficiency. These tumors are known to bleed, they continue to bleed, and the iron continues to drop. And so we have to ensure that we replete the iron. And also, if patients have had a total gastrectomy, you just can't absorb it. You just can't absorb it orally. And at the end of the day, we want to improve the delivery of cancer care to our patients. We do want to ensure that they get all the benefits of the chemotherapy, our targeted therapy that we're giving our patients, and at the end of the day, to improve their quality of life and, of course, their quantity of life at the same time. That's it. Thank you. Any questions? You want to do questions?
Yeah, I have a question. Christine, you say that people with stomach cancer cannot absorb iron, but wouldn't that be true for all essential nutrients besides iron? Why just iron?
Well, iron is known to, so that's a good question. Nutrients are absorbed throughout. not only the stomach, but also the small intestine as the food digested down. Iron is a key element, though, in terms of developing the iron deficiency. Well, for sure, right? That's why we see weight loss in our patients with stomach cancer. But the nutrients can be absorbed more distally. So further down, further away. And B12.
I just want to make a comment. I'm fortunate to be a patient of Dr. Brezden's, and I did the iron infusion, and it was life-changing for me. Absolutely life-changing. I go to the gym every day now. I went from being a couch potato to working out. Oh, I did it a year ago. Yeah. So thank you.
Oh. Awesome. We actually have some questions from online. Is there a more specific blood test checking iron levels for total gastrectomy patients versus those with a stomach?
No, it's still the same. So every patient gets into the hospital, gets a CBC, which is basically looking at your hemoglobin. Doesn't matter if you're sick or not, you typically get a CBC done. That's a trigger. You don't necessarily have to be anemic to be iron deficient. So that's something that has to be looked at. So we look at ferritin, we look at total iron binding capacity, iron and total saturation.
And
And
then,
you can do iron as well, sorry.
okay. And then another question from someone online is, does the sublingual iron work for TG?
Sorry, just
Does sublingual iron, I think iron supplements, work for total gastrectomy?
sublingual iron. I don't know, actually. I haven't seen sublingual iron, but probably not, because it's going to go through the GI system as opposed to directly into the vein.
Yeah, that was it.
Test. Good afternoon. I'm curious. I've had my duodenum taken out. I've had a TG, but I've just been taking iron pills off the shelf orally. And should I be demanding to my GP to put me
Well,
on?
just take a look at your iron levels. The way the iron is bound, there is very little that can be absorbed distally as well, but very little, just how the binding of the protein. So typically our patients who've had a total gastrectomy, we recommend intravenous iron. And your stores are repleted. Don't forget, you also have iron in a lot of foods. But the oral iron that you're prescribed typically is absorbed in the duodenum, right? So if patients who have had a total gastrectomy with their duodenum removed, you just get your iron checked. So you're probably on iron because you're iron deficient. And so just see how well it's working. But there is intravenous iron which will replete you immediately within 45 minutes.
Well, I've been taking iron orally like every night. But,
With vitamin C, right? With orange
yes, I take a lot of vitamin C as well. I get a B12 shot once a month.
Yeah,
Can
so
I-
B12 is different. You need to get the shot.
But
Yeah.
what I'm
yeah,
saying is, can I
B12
get
is
them
different.
both done in the doctor's office?
Intravenous iron typically has to be in an infusion center of some form. So we
Okay.
do it in the chemotherapy suite because it's a 45-minute infusion
Okay, thanks.
with the monoferric. The other ones are three-hour visits.
Is iron replacement for gastric cancer patients who are deficient in iron, is that an accepted standard of care?
Intravenous,
Yes.
it should be.
Yes. Is it?
It should be.
And so, for example, in large centers like Toronto, various...
Yeah, so you'll see more and more oncologists for sure using intravenous iron. You'll see
Are there
more and
any
more.
patients that wouldn't receive such a treatment? Any patient groups?
So with the monoferric, there's less of a hypersensitivity or acute reaction. There have been some formularies that patients would get acute reactions, almost like a hypersensitivity reaction to it. But that being said, there there is, it's not that common. It's like I think it's less than 1%, but I have to take a look at it, but it's not very common. So if patients do have some contraindication to intravenous iron, they're not going to get the iron. But overall, the general population should be able to tolerate monoferric.
Thank you.
Sorry, I just got one question. How often is the treatment for the intravenous for iron?
So it depends how deplete the patient is. So I've given intravenous iron infusions once a month, 2-3 times. I've been getting it once every 6 months, once every year. Like, it all depends on what the levels are. It depends what the levels are. And the loss, right?
So we're gonna save some more of those questions for our third panel. Thank you so much, Dr. Brezden. Very innovative approach to long-term care with gastric cancer patient, and thank you so much for your ongoing support of My Gut Feeling. The next people that I'd like to introduce are two social workers, Emily Barca and Joanne Sue. Both work at Princess Margaret Cancer Center, and they will be presenting topics on how to help patients with emotional and practical support through their cancer experiences. Please welcome them.
Good afternoon, everyone. My name is Emily. This is Joanne. We're the two GI cancer social workers at Princess Margaret, and we both work with people with stomach cancer. We wanted to thank you so much for allowing us to come speak with you today. And it's been wonderful to hear about everyone's experiences and also the expertise that you bring to the room today. So we will be talking today about coping with stomach cancer, and we've decided to focus on the experiences of both patients and caregivers. We hope that our presentation will be helpful to you. We wanted to begin by letting you know that you are not alone in this journey. And we also hope that we can figure out how to use this clicker. So today we'll be talking about the effect of gastric cancer on patients, caregivers, and families, how to access support, some ideas for coping and self-care, and also thinking about the future.
So we really look at cancer as a shared experience. In our practice at Princess Margaret, we work with many different people who are coping with different cancer diagnoses. And although each person is unique, here are some of the common psychosocial issues that we see. It's very common to feel strong emotions about this experience, including anxiety and low mood. Related to this, many people experience certain loss of certain identities. For example, you may have had to stop working because of your cancer treatment. People often experience change in roles within their families, within their homes. They may not be able to take on some parenting roles or household roles as well. Our patients often speak about changes to their relationships, particularly the relationships with their partner or closest family and friends. They also speak about changes in their body image and struggles in in preserving their dignity. Some of the emotional impacts on patients. You may experience emotions due to fear of uncertainty of the situation, causing you to experience anxiety, as I said before, depression, thoughts of hopelessness, feelings of isolation and anger. You may also feel the need to protect or not burden others, your family members, your caregivers, the ones that you love the most. And this can be experienced as not wanting to let other people down. And it can contribute to some problems communicating and not feeling supported in some ways. Patients do often speak of their appreciation for and gratitude for their loved ones who support them through this process. So cancer is certainly a physical disease. It's also with physical symptoms, but it's also a social disease that affects the patients and everybody around them. We wanted to give special focus to the caregivers in our presentation today because including all of you in this room, because it really is a shared experience that we all go through. We wanted to, so it's completely normal reaction in terms of like the distress you might be feeling as patients and as caregivers going through this experience. And cancer care cannot function without your loved ones. You really are, as caregivers, the backbone, invisible backbone to the healthcare system. And we believe that patients and caregivers are the experts of their experience, and we strive to support you through your journey. Relationships are inherently impacted by cancer, and a diagnosis can lead to changes within many areas of your family or support system. Together, we can make a plan to address family members' needs, and this can involve supportive counseling with one of us for your patients, for yourselves as caregivers. We discuss how to have conversations around how to tell family members, sometimes children, and how to ensure everybody's needs are recognized, respected, and addressed. It's important to ask questions and to share your thoughts and concerns with your healthcare team, and we can help facilitate that as social workers. Here are some of the emotional impacts on caregivers. Coping with a loved one's cancer can cause many difficult emotions for caregivers, yet caregivers don't often feel like they have the permission to feel this distress. You might notice that many of these emotions are similar to those experienced by patients. These are normal. You're not doing anything wrong if you experience them. However, as we'll discuss next, you don't need to manage them on your own.
Okay, so what is supportive care? So the last speaker spoke a little bit about the medical side of supportive care, and when we think of supportive care, we also think about psychosocial supportive care. So we're both part of the Department of Supportive Care, and it helps patients and families cope with physical, practical, emotional, and spiritual challenges of cancer. Supportive care can improve the quality of life of patients with cancer, as professional supportive care professionals, we can help advocate for increased supports. You may meet many different practitioners who are part of the supportive care team. Us, social workers, psychiatrists, psychologists, palliative care physicians, nurses, supportive care practitioners, spiritual care practitioners, and working with many different professionals can help give you help and support and hope and address your many different needs. So you might already be aware of some of the different types of support you can access, but we do find that sometimes people come to us and they've been referred by their doctor or maybe a nurse on their oncology team, and they don't actually know what is available to them, so we just wanted to run through a few of these today. Of course, there's one-on-one counseling and family counseling. An example of this at Princess Margaret would be CALM therapy. This is for people with advanced or metastatic cancer. Support groups, such as the support group offered by My Gut Feeling, information groups, skills-based groups, and again, at our hospital, we do have a caregiver clinic run by a psychologist and psychiatrist, and we've included a link here actually, which has many different resources, both in the hospital and in the community for caregivers. So how can we help? We can be a key member of your oncology team. In Canada, many social workers who work with oncology patients are master's trained, and we also undergo additional training to provide specialized care to you. You can access our services by speaking to your oncologist, nurse, or another member of your healthcare team. And in Canada, if you're accessing social work in the hospital, it is free. So these are just a few different things that we can help you with. We're around if you have any other questions about them after our talk. You can access support at your hospital or cancer center, through your family doctor. Some people have employee assistance programs, and also some people do choose to access resources privately. We've compiled a list of resources in Canada and also internationally. This is just a sampling. There's many more places where you can access support.
There are many ways, different ways to cope if you or your loved one are going through gastric cancer. And what works best for you may not work for the next person. We want to acknowledge that despite all the coping tools in the world, there may be very hard days. The lists are inspired by our patients and our caregivers that we work with. Some of them building good relationship with your medical team, making sure that everybody's on the same page, creating a structure and keeping daily routines. Having a plan to return to work if that's to you if you're working. Spending time with your loved ones. And we also acknowledge, for caregivers, we encourage you to be gentle, forgiving with yourself, allowing yourself to feel your emotions, asking other family or friends if they can help you with your loved one's care. You might want to consider counseling for yourself, and then also importantly to recognize the signs of caregiver burnout and reach out for support, because there's no shame in needing some help. Some questions you may want to ask your loved one with cancer is, what was it like to hear your diagnosis? What and not how are you feeling? What do you hope for? How are you coping, and how can I best support you? And self-care. A very important part of coping is self-care and self-compassion. As mentioned before, one very important aspect of self-care is to give yourself permission to take the time for yourself, to do the things that you enjoy, but also to feel and sit with the emotions that you might be experiencing.
For people with cancer and their caregivers, the future is full of uncertainty. Sometimes it brings up so much anxiety that you may want to avoid talking or even thinking about it. That might be a reasonable strategy for a while, but we have found that when people are able to talk about the future, including their hopes and their fears for the future, their anxiety actually tends to lessen. You might have heard of the term advanced care planning. This is a process which allows patients and their loved ones to talk about your or your loved one's values and wishes for the future. While these conversations are often not easy, we have found that they can help you and your loved ones feel more prepared and in control. It can be easier to start this process earlier on, and you can always change your mind about decisions you've made. We have included a few resources that can help you with this process. So the last thing we wanted to talk about today was palliative care. So we work very closely with our palliative care colleagues, and sometimes we'll actually suggest a referral to a palliative care doctor if we think it could benefit somebody. So we did want to speak about the misconceptions that sometimes exist around palliative care. People often think palliative care is only about end-of-life support, and that is true, that palliative care teams do support people at end of life. But many of our patients actually do see palliative care for other reasons. Palliative care focuses on pain and symptom management and takes a holistic approach. Many of our patients actually see a palliative care physician alongside other oncologists. So we just wanted to end with a final thought, which is that it's normal for you and your loved ones to have a range of emotions. Some of them may be very difficult about your situations. We truly believe that you ultimately know what you need, and we want to support you in accessing what you need. We also do think that you shouldn't have to suffer alone, and we invite you to reach out for support no matter where you are in your journey.
Okay, we have a question online, actually related to palliative care. Someone was asking, what is the best palliative care option if the patient does not want to take a strong chemo regimen?
I don't think we can answer that question. I think that's more of a medical question. But it might be something for this person to discuss with their medical team. Yeah.
What is the best palliative care option if the patient does not want to take a strong chemo regimen?
So there's depends on the chemotherapy. Chemotherapy can be tailored to the patient. It can be either a lower dose or it can be a different type of chemotherapy, but there are different chemotherapies that can be discussed with the patient and offered to the patient, knowing what the response rate and the survival rates are of the chemotherapy.
And you can also receive palliative care while you're on chemotherapy. So care from our palliative care team is alongside with getting active treatment or even palliative chemotherapy.
So we come to our final speaker presentation of the day. So we met Melani about 5 or 6 years ago, virtually, only by phone. We were doing some work with Debbie's Dream Foundation that's based in the US, and Melani was incredibly involved in that, and so we would meet with her on the phone, but we never got to meet in person. And Melani has an incredible story. I will just say that she's just so full of life, and she is a stage 4, 10-year survivor. So she's a miracle. So Melani Vincelli.
Okay. I want to thank everybody for staying. The best is last. And I want to give a shout out to the United States because I have a bunch of family and friends watching. So like most women today, I always put my health concerns last. So in January of 2009, when I noticed some pressure under my breastbone, I ignored it. It felt like my bra was too tight. I remember saying to my husband, if I told my doctor that I feel like my bra is too tight, he's going to tell me to buy a bigger bra. Besides, I was too young for anything to be seriously wrong. I was only 49. I had a stressful job. I was too young for anything to be seriously wrong. I sold technology to businesses, and with the recession in full swing, I wrote it off as stress. I already had IBS, so that had to be it, or maybe an ulcer. My husband owned his own business at the time, and things were slow. Between his business and my job, my bet was on the ulcer. Besides, my then 21-year-old son needed to have sinus surgery. Before I even thought of doing anything for myself, I had to think about him. So if the sensations continued, I would go for a checkup. In May, I was starting to have some nausea, and I wasn't eating that well. I had lost almost 30 pounds. A nice surprise. So I thought a trip to my family doctor was in order. My doctor asked me why it took me so long to come and see him. I answered, well, that I really wanted to lose 50 pounds in case he reversed the symptoms and I started to gain the weight back again. He did a full blood workup, and I went home to wait for the results. The phone call came the next day. You are anemic, he said. Okay, a bleeding ulcer, I thought. He wanted me to see a gastroenterologist for an endoscope. The gastro is a friend of ours through a mutual friend and has seen my husband for acid reflux and other problems, so it was a very cordial visit. He scheduled me for the endoscope that week. So now it's June 2009, and I'm sitting in the recovery area of the hospital after my endoscope with my hubby by my side. I was one of the first appointments that morning, but the doctor keeps going past my bed. People that came in after me are going home. Finally, he approaches the foot of my bed. We found a mass, he says, and I think, well, that's a funny way to tell me I have an ulcer. Wait, a mass? Cancer? Yes, he says. Stomach cancer? Adenoma carcinoma, and it's quite large. He wants to do a CAT scan to see if it's spread anywhere else. Spread anywhere else? I can't even comprehend the fact that I have cancer in my stomach, which is really supposed to be an ulcer, and now we have to go looking for it in other places? Okay, let's see if I can do this. CAT scan results were in. I had a lesion on my liver and a spot on my lung. I went from thinking I had an ulcer to stage 4 stomach cancer, and with that, my whole life changed. Choosing a treatment should be easy, right? Follow a protocol and you get better. I went for 3 different opinions before I found the one that I believed in. And my wish was really simple. I just wanted to live. At the small community hospital where I was initially diagnosed, I had my stomach in and out of me numerous times, figuratively. I would receive a phone call telling me that they scheduled the surgery. The next day, they would call and say, nope, we're going to do chemo first, and then the next day, time for surgery. The reason why the smaller community hospital was having such a hard time deciding on my course of treatment was probably due to the fact that they had not seen that many cases of stomach cancer. In the United States, it is better to go to a bigger university hospital with our disease. The reason being that they hopefully have seen more cases of stomach cancer and know how to treat the disease appropriately. One prominent hospital told me that I only had 6 to 9 months to live and that I should enter into clinical studies as soon as possible. I was told that I would never be a candidate for surgery. I thanked them for their opinion and promptly left the office. My husband turned to me and he asked, "Where are you going?" And I replied, "I don't believe them." I was in for the fight of my life, and I wanted a team behind me. I wasn't going to waste my time and energy trying to convince my doctors that I was going to survive. Keep in mind, as confusing as all this was to us, I was very lucky. I think I have the wrong slide. Hold on. Let's see. Hold on. What happened? Where'd they go? Okay. Oh, well. Okay. Keep in mind, as confusing as this all was to us, I was very lucky to be able to get so many options. The insurance that I had at the time did not require referrals or additional paperwork to see any doctors or hospitals for their additional opinions. Some insurance companies inundate their patients with so much paperwork, there are actual companies set up to help you navigate through the blizzard of paperwork. As it turned out, the hospital I chose was in my approved network. I had no clue and never even checked about this. I did not know that, and I had to do what I had to do at the time. I just wanted to go to the best hospital to handle my disease, and whether it was covered by my insurance was a secondary thought. But as it turned out, even after I met all the criteria that I was supposed to meet with my insurance company, I was still one of the 66% of Americans that had to declare bankruptcy. Here is the reason why. I was now living on a third of my salary provided to me through our government called Social Security Disability, but I had the same amount of bills each month. Even though I only owed about $5,000, which is relatively low in the United States for medical bills, I still was having less money coming in to spend. We had to declare bankruptcy in 2012. It was the best thing we ever did. It took so much pressure off of us. We were able to keep our house, and I was able to concentrate on healing. That is the real shame here. Not only did I have to fight for my life, but I had to find the correct path for me to follow to live with a very rare cancer, but I also had to worry about throwing my family into economic turmoil. After all this, I finally found a different hospital that believed everybody was curable, a nicer option that followed my feelings. I started my chemo in July 2009. After 3 rounds of cisplatin, taxotere, and 5-FU, 3 rounds of cisplatin, taxotere, and 5-FU, I had a CAT scan done, and I was totally cancer-free. There was no trace to be found. I finished the therapy and had a total of 6 rounds of chemo. I returned to see my surgeon oncologist in November 2009. Needless to say, my doctor was very happy to see me. He didn't think that I was going to survive, but the chemo did its job. It was at this appointment that he recommended that I have a total gastrectomy, a complete removal of my stomach, almost unheard of as a form of treatment 11 years ago. He said that people that opt not to have the surgery see a return of the stomach cancer within a year and they don't know why. Well, that was a no-brainer for me. We scheduled my surgery. On December 7th, 2009, I had my entire stomach, the part of the liver that was originally affected, and my gallbladder removed. He attached my esophagus directly to my small intestine. I have no pouch or sac. It was a complete removal. It was an 8-hour surgery. All the pathology reports came back clean. My doctor leaned over my bed, gave me a kiss on the cheek, and said, "Before you had months, now you have years." I've been cancer-free ever since. Having no stomach is like an ooper-duper gastric bypass. Ooper-duper. I eat small meals throughout the day, and my husband can verify that because he's gained so much weight. I love pizza, steak, and submarine sandwiches. Spaghetti still gives me a little trouble, and so does chicken, but I can get through it. I can't eat a lot of sugary things, but then no one should anyway. I know my limit, sort of. I lost 80 pounds, but I gained 16 pounds back since the surgery. Okay, this is where it gets interesting. Fast forward to November of 2014. After a normally scheduled mammography and some lengthy testing, I was diagnosed with atypical lobular hypoplasia in my left breast. Atypical hypoplasia are changes noted in breast cells. It is also a precursor to breast cancer. Since I am so active in the stomach cancer community, I knew that women that have had stomach cancer are more susceptible to lobular breast cancer. And the doctors don't know why. Where was mine? Lobular. So with this new revelation, I was genetically tested. The geneticist was convinced that I carried the CDH1 gene, which is considered the stomach cancer gene. Her thought being that since I was so young, when I was diagnosed, 49, there really was no other factors that would lead to any reason as to why I would have gotten the cancer. And with all that being said, and viewing that as a very valid hypothesis, I received a phone call from the geneticist with my results. "Are you sitting down?" she asked. Never a good way to start a conversation. "You are BRCA2 positive. I have the breast cancer gene. That means that although I had an 85% chance of getting breast cancer with this gene, I got stomach cancer. Because of my prognosis, I had a proactive bilateral double mastectomy performed. I had already had a hysterectomy when I was 40 due to non-cancerous events. Otherwise, I would have had a total hysterectomy done as well. All the tests came back showing no evidence of breast cancer, but I still feel that I made the best decision. I have rolled the dice and cheated cancer once. I didn't want to press my odds for a second time." Okay, I don't think this is all messed up, but that's okay. You'll just listen to me. "One of the biggest challenges we face as survivors is how to survive. No one teaches you how to do this. And yet, and you look at the slide that isn't there, survivors are going to make up 5% of the US population. Oh, I knew how to fight. I knew how to stay strong during my treatment, mentally and physically, but I never gave a thought on how I was going to live my life after all this was done. Honestly, I was more prepared to die than I was to live. My affairs were all in order. I had a burial plot. I even knew the color casket I wanted to be buried in. So I did some research on it, and these are the points that hit home. Here are the major issues, and those that are survivors in the room, these are going to be spot on. Damocles, I can't say it, syndrome. According to Greek legend, once Damocles realized that a sword was dangling precariously over his head, he could no longer enjoy the banquet spread in front of him. In the same way, the ghost of cancer hangs over some cancer survivors. They can become emotionally paralyzed and have a hard time deciding to get married, change jobs, or make other major decisions. Fear of reoccurrence. Given cancer's potential to lay dormant for a while and then spread, cancer survivors often experience ongoing fear of reoccurrence. Follow-up medical visits, unexplained pain, even sights and sound they associate with treatment can trigger bouts of anxiety and fear that are as debilitating as those that occurred during cancer treatment. Survivor guilt. This is my biggest culprit because I'm watching everyone that I've lived this disease with pass. Although happy to be alive, cancer survivors may feel guilty that they survived while fellow patients they became friendly with during treatment or as part of a support group did not. Early after a diagnosis of cancer, people first ask, why me? When survivors think about those who have died, they tend to ask, why not me? And I feel that with our disease and the very low prognosis we are given from the beginning, the survivor guilt plays with those that survive the hardest. Only recently has this idea of helping those that are surviving come into play. The reason is because more people are surviving a cancer diagnosis than ever before, and the mental issues need to be addressed in order for the survivor to thrive in their newly given role. In May, okay, wait a minute, I think I saw this one. We'll go back. In May 2014 edition of AARP magazine, now you're all supposed to say you don't look old enough to subscribe to AARP magazine, I don't hear it. There was a very interesting article named Surviving the Jolt. It fully describes my new life story. They say that in a midlife jolt, a person either derails or reclaims their life, making it better and stronger. They call it post-traumatic growth, or PTG. The term was coined in 1995 by a professor of psychology at the University of North Carolina. Like post-traumatic stress disorder, which is its sister condition, which we all know, not all people get it after a life-changing shock. But one consistent finding for people that do experience PTG is that we have survived a set of circumstances that have rocked our world. We feel that the event has happened to us for a reason and that we must find the reason. Well, I found that meaning in January of 2012. I was on the Dr. Odd show. Don't blink, you'll miss me, my 5 seconds of fame. And then they put me up talking, and instead of saying, Melanie, cancer survivor. Melanie from New Jersey. Melanie, age 52. I'm like, oh, okay, I'm really happy I'm here, but now 35 million people know how old I am. On that show, I met a fellow survivor, Debbie Zellman. Debbie had started a support network where other stomach cancer patients and their caregivers could speak to stomach cancer survivors or their caregivers that have experienced the identical journey. That was my outlet, my chance to help others. I do this because when I was going through my treatment, I had no one to speak with about my disease. It occurs so infrequently that finding another person with stomach cancer is so difficult, and one that has survived it is almost impossible. Like my gut feeling, advocacy groups are such an addition to any hospital because it puts people together that get it and they understand each other. Debbie's Dream Foundation gathers us all together in one meeting place. We mentor other stomach cancer patients and their caregivers. We also travel to Washington, D.C. once a year, and in one full voice, we ask for more money for stomach cancer research. I wish I could say that in 8 years of visiting Washington, we have gotten more money than we needed. But sadly, that is not the case. But it is certainly not all bad news. Because of the constant efforts of DDF, the United States government has gone from $0 allotted to stomach cancer in 2012 to now, in 2019, it was part of $90 million designated for rare cancers. In addition, DDF provides free support to thousands of patients and their families through its patient resource education program, hosts free educational symposium webinars, just like My Gut Feeling, and directly funded over $1 million in research grants. It provides free support to thousands of patients and their families. It hosts webinars. It's just like My Gut Feeling, but the US version. And this is needed because the instances of stomach cancer in younger adults are rising and the odds of surviving the disease are declining. My other reasons for my survival are my family. Okay, that's Advocacy Day for DDF. I'm in that picture, you can't see me, but I'm there. And it was cold, because it's always in February. Ah, there you go. Okay, my other reasons for survival are my family, and I hope he's watching because he's gonna kill me. When I was diagnosed in 2009, my son was 21. Let me see. Okay, he's important. I love you, honey. Wait, there we are. Oh, I do have a picture of Billy. Billy, I'm glad you're not watching. Okay. When I was diagnosed in 2009, my son was 21. If he would have given me a grandchild then, I would have killed him. But when he was 27, he met a girl and they had a baby, my granddaughter, Scarlet Rose. And she was born on our wedding anniversary, so my son better never forget that date. Unfortunately, the relationship did not last, but the child is the best thing that has ever happened to my son, my husband, and to myself. The split was very amicable, and they share custody. My son has been living with us for the past 2 years, so we have had the pleasure of helping to raise her. I am helping to raise a grandchild that I was never supposed to live long enough to know. Where do you want the pony, honey? No holds barred. Okay, and here it gets ucky. And for those of you that are wondering if the BRCA2 gene has been passed on to my son, the answer is yes, unfortunately it has. I made him get tested, and he is BRCA2 positive. He did not want to know, but not for what it could do to him, but for the fact that his daughter may have it. She's only 4, so he didn't want to worry about it for the next 10 years or so before she could be appropriately tested. But I told him that knowledge is power, and now that we know he has the gene, we might be quicker to get her tested at the appropriate age than we would have by not knowing. By the time she is tested, my hope is that the science will be available for her that will make the cancer a more treatable disease, even curable. Thank you so much for having me here to speak. We need to work together to help raise awareness and to eventually find a cure. So right now in today's world, I stand before you as a miracle. One of the 4% of the people that get stage 4 stomach cancer and survive for more than 5 years. But through new treatments and more stomach cancer research and funding, I am hoping soon to be just another cancer survivor.
We would like to introduce, or we would like to invite all our speakers to the third panel. So this includes Dr. Brezden, Emily, Joanne, Melanie, and then also Lena, who is an 18-year stomach cancer survivor.
Nice. 18? Wow.
Why don't we move it this way?
I do. As my husband says, I age like a fine wine. 3B.
That's fantastic.
So we'll open it up to questions first.
I was diagnosed in 2001, so do the quick math, I'm 40.
Wow, you look fantastic.
Very much again. I would like to ask upon a clarification from Iron Gut Doctor. Do I understand you clearly that you mentioned that Asians, the stomach tend not to be able to absorb iron as easily, so that's why there are more cases of stomach cancer? Is that right? Or did I not understand you correctly?
So Asia has the highest incidence of stomach cancer in the world.
Oh, in the world?
In the world, yeah.
Well, is it due to because of the ethnic background or the food, or what could be the reason for that, please?
So good question. It's whether or not there is an environmental cause for it. There is a high salted diet. I can say in China, I travel to China every year, and China is a very high salted diet. Salt does drive, nitrates, salt can drive, specifically if H. pylori is present, can drive into the formation of stomach cancer. Smoking, alcohol, but it's a very good question whether or not it's environmental as well. You'll hear East versus West. We talk about Asia having a different type of disease or response to therapy compared to the West, so the rest of the world outside of Asia. But we're still trying to figure it out. Now with oncogenomics, I think we're going to be figuring it out a lot better, looking at what's driving these tumors at the genetic level.
Thank you.
Hi, question probably for Dr. Brezden. I'm wondering if you could comment on the long-term use of stomach medication like ranitidine and Nexium, because there's been a lot of controversy in the media about it causing cancer, and I'm a Lynch patient. So I was just wondering if you could provide some insight into that.
So it's a very good question. I'm not the expert in the use of these proton pump inhibitors, but it certainly does change the acidity of the stomach and does change the normal bacterial content of the stomach for long-term use. And sometimes they'll say not to use it for long-term use, just use it when you have, for example, heartburn. But I don't really know the evidence to say that this leads to cancer. I can tell you iron, if you're taking oral iron, it's not going to be absorbed very well unless you're taking it with vitamin C, as I said, because you don't have that acidic environment anymore with a proton pump inhibitor. Do you guys want to comment on the long-term use of PPIs? I'm going to ask my surgical colleagues.
So yeah, the long-term use of PPIs is usually not recommended unless there's like very specific reasons, like refractory, either ulcer disease or gastroesophageal reflux disease, because we probably don't know what the really long-term, like years and decades implications is, and it definitely changes the pH environment. But what that means to the absorption of our other nutrients is we don't really know. Whether or not it's a specific risk factor for development of gastric cancer, I don't think anyone has identified that. I don't know if Natalie wants to.
You're changing physiology, and long-term we don't know because these are relatively new drugs, so I think that's one thing. The news releases about Zantac are about a very specific compound and a very specific cancer profile, so probably not anything everyone should worry about. But what we do know is that the incidence of gastroesophageal and esophageal cancers are increasing, and that has a lot to do with reflux and PPIs. Maybe not caused by the PPIs, but led from the reflux and the obesity. So I think the landscape is changing, and it's something everyone's looking into in terms of research, but something we should all be aware of.
So whether or not PPI is just a Band-Aid for the reflux, and then the reflux continues to cause inflammation and then increase disease at the gastroesophageal junction.
Probably the reflux that's creating the cancers, and then the PPIs are the Band-Aids, yeah.
Hi, this is Shadabia. So one of the challenges we are facing during my dad's currently ongoing chemotherapy, his loss of appetite. So me and my family, like at times we have to sit with him for hours to convince him to eat, which he doesn't want to. So one of my mother-in-law had a gastric cancer, and he went for a cannabis and CBD thing to increase her appetite, and which worked for him. So does it really, cannabis or CBD in some way helps in terms of increasing appetite, or somewhere helping the patient to eat more or to calm down more?
Sorry. So CBD, well, we know that, back in the days when we would prescribe marijuana and not refine it just to CBD, that it was an appetite stimulant.
Oh, absolutely. I smoked pot my entire time.
No, because
I'm sorry, for medical reasons, why it's not legal in the United States, I have no idea, because I smoked pot the entire time. And I got the munchies. It was a win-win. The nausea would go away. I'd wake up and I'd eat a whole bag of potato chips. It was fantastic. But also, too, there's a medicine that we have in the United States. It's called Megace, and your father will eat the wallpaper off the walls. It makes you so hungry. It's a very strong appetite. Thank you, stimulant. But I'm telling you right now, the only problem I have with CBD oil in the United States, it's not regulated, so you don't know what you're getting when you buy it. And unless you're buying it from someone that is reputable, if that even exists, then you don't know what you're getting. Marijuana, I'm telling you right now, I smoked and it was great.
Okay. I mean, it's a very same situation in India. It's not illegally available, but it's available in the underground market. I mean...
Yeah, well, you can get CBD. The problem with us in the United States is I can go to my local bodega and buy CBD oil. So I don't know where it's coming from because the FDA hasn't really regulated it yet for us, so you don't know what you're getting when you go and buy. You can buy CBD everything. So, but they do the same thing now with marijuana, or so they tell me. You can buy edibles and all kinds of stuff now. So they say. I haven't done it in a while. I don't know.
I would also see how he's doing in terms of coping, whether or not there are some like depressive symptoms or anxiety in that respect. Sometimes when they are feeling or having some coping struggles, the appetite does decrease. So I might take a look to see how is his mood, how is he coping, how is he doing day to day, and then see if that's also affected.
He is quite depressed because he had a lot of plans, but suddenly it came all of a sudden, and it has put a break or halt on everything. So he does feel that there's a lot of unfinished business.
Yeah.
Which makes him a lot of depressed.
Just a quick question. Melanie, you'd said 10 years ago that you had a TG and that was very rare. So 18 years ago, was TG also the procedure?
I feel like a dinosaur up here, right? I mean,
I was expecting an 80-year-old
well,
woman
I know.
to be walking
Trust me,
downstairs.
I don't think they know what to do with me back then. So actually, what I was told by my surgeon, and I still love him, and he's still practicing. He said, best case scenario, you wake up with a scar, but worst case scenario, you don't. So he went in laparoscopically first to see. To see if he could operate. And good news is he could. So then I was cut open, and I think I've got about 20% remaining of my stomach, yeah. So his one goal, and I think he felt sorry for me at the time, he said, I'm gonna try to keep as much of your stomach as I can. And I was fortunate to hang on to about 20%.
It must have been really scary because it was just so rare.
Very rare, yeah, because I was female and young, and yeah.
And I was gutted like a deer. I look like, my bikini days were over anyway, but they are definitely over now because he had to go in, it was an 8-hour surgery. And then it was really funny with me, he took out lymph nodes, and when he tested 2 of the lymph nodes, he had said to me later, he said, they look suspicious to me. He says, I'm not gonna lie, he goes, I didn't think they were gonna pass the muster. He said, but they came back negative, so yeah.
And did you do chemo as well?
So I did 6 months, so back then it was 5FU, I think it still is now. And so it was 7 days straight of it for 1 week, so I'd have 3 weeks, 1 week on, 3 weeks off, and that lasted for 6 months. And back then they said, if we also give you radiation, it'll increase your rates a little bit. So I did it. I had 25 days of radiation as well. But I mean, I was fighting the odds of 1 in 15 or 15% chance. So I was like, do whatever you want to me. I just want to live. Yeah. So yeah, and those were, I think for me, it was the toughest month when it was the chemo radiation one. And yeah, I hit some lows, and there was, I mean, you talked about diet, and when you feel like crap and you can't get out of bed and swallowing your own saliva, it hurts. The last thing you want to do is eat. So my poor father went out, and I don't know if there was Costco at the time, but the only thing I could stomach was blue Gatorade and green apples. So probably for a couple of months, that's all I ate. But if that's what I could take in, that's what I took in. The radiation was the toughest for me personally. The 5FU was not pleasant, but yeah.
You look amazing.
Thank you.
So just a couple of notes. Lena was one of our speakers at our first conference, and you can watch her incredible story if you go online to our website.
Can I add something else?
And she also wrote DNA. But she also wrote DNA Moments, which is a book we have a few copies of. So she's just incredible all around too.
I'm just gonna shameless little plug here for, I'm very, very passionate about fitness and living a very healthy lifestyle. And I think for me, it's what helped save me in my lowest of my lows when I lost all the weight and was probably 80 pounds dripping wet with rocks in my pocket. I went to a gym because I felt I needed to get stronger. And anyway, so to this day, I think fitness, so whether you work out or you don't, or whatever it is that you do, if you're a caregiver or a patient, I think to get out and to walk and to get your blood flowing can do so much for you physically and mentally. And maybe you, but I'm sure you do. I'm sure you run around your house. Okay, well, this is my moment. Hold on. So I'm passionate about encouraging that, and I've had complications since, and I've had to have surgery since, and I've rebounded impressively, and I attribute it to my fitness and being healthy. And I always say, if God is going to do this to me again, and if I am a cancer patient again, I hope to fight it just as well, trying to be as healthy as I can. So go out there and do something for your body. Yeah.
So that's a very good point. So the American College of Sports Medicine just put out the exercise for cancer patients, even during chemo. And it's recommended that patients do exercise even while on chemo, 3 times a week, 30 minutes, to the point that you can't speak full sentences, just grunt words out. And also strength training for 2 of those days. So 5 days in total, but it's really important. And as you said, it does pump the chemo through. It gets it to everywhere it's supposed to go. So I think it's very important that our patients do think about cancer rehab and exercise.
And
Thanks for
just
putting
to
that
let you guys know, Lena has generously donated her time. She actually made some exercise videos of for patients of even like simple things of how to get out of bed after surgery. So those will be available online shortly. So stay tuned for that. We have a couple of questions online.
So first of all, Melanie, William says he is watching. He says hello.
Who is watching?
William, your husband.
My husband is watching.
Yeah. He made a comment. He says I'm watching. So I just have a couple of questions from a bunch of people online. So first off, where's the one from earlier?
Was he nice at least online, or did he have comments to say?
It was just one sentence. He just says, hi, I'm watching.
I'm watching, okay.
Yeah. So, Dr. Brezden, someone's asking, can iron infusions produce any negative side effects? How common is an excessive dosage of iron via infusion? And can it raise ALT and AST lab results?
So typically if patients are on chemotherapy, that's the most common cause of increasing liver numbers. 1 gram typically should not. And, you know, you just follow the patients with all the parameters of red blood cells, of hemoglobin, for example, and the iron levels. With respect to negative effects, sure. I mean, you can have an infusion reaction that has been monitored. And just to point out, then, in the U.S. is different, but in Ontario and in parts of Canada, obviously, iron is not necessarily funded, so patients will have to pay out of pocket or with their insurance to get iron. There is the iron dextran, the Venofer, that's 3 infusions, that we can get through an exceptional access program for our patients. So there is that opportunity, but hopefully we'll get the other one on the formulary soon.
And I've had in the almost 11 years that I've been like this, I've only had to have 2 iron infusions, which is absolutely amazing because some people have to have an iron infusion every 6 months. And when I recently went, they had just switched over to a brand new one that you get once, you get it in 2 weeks, once 1 week, and then another one the next week. And I had no reaction to that, but I had had one about a year ago, and it was a different one. And I actually had a reaction to it, but it wasn't like a very intense reaction. I had, and for some people, they go through this. I had diarrhea, and I was a little fatigued, and it only lasted for like maybe 2 or 3 days. And then iron infusions are the best gift of God ever. If you don't have a stomach and you feel the fatigue, oh my God, you go for an iron infusion and you are pumped. You are like, where have you been all my life? This is fantastic. So, and we know when we need one. And what I wanted to ask you was, when I had gone and I'd had a full workup done, my iron wasn't low, but my ferritin was. And when my ferritin was low, my endocrinologist, because my thyroid is also a mess, don't ask, and my endocrinologist had said, you're going to need an iron infusion because your ferritin is starting to go low. Is that a precursor to the iron being low?
Yeah, so ferritin is the stored iron. So ferritin is drops. The problem with ferritin is it's called an acute phase reaction. So we see it with liver, that's probably where it's coming from. But ferritin can go high to 100, for example. But to me, still, with a gastric cancer patient, with even a ferritin of 90 or 100, to me that is considered on the lower end. Okay. We have different parameters, and if the iron saturation, depending on what the lab has as its parameters, but that is typically what we're looking at when we're trying to give patients iron, if that's low.
And then, along the same vein, what is the difference between iron infusion and iron injection? Is the risk for anaphylactic shock the same with an infusion?
So iron infusion, typically, don't give an, you can give an iron injection, I apologize. You can get an iron injection, even when a ferret can give an injection. We don't typically do the injections, we do the infusions. I believe it's just safer. We give over 45 minutes.
Okay. And someone else is asking, what is the best approach in seeking a second opinion? I do not want to offend my oncologist, but I feel like I need another opinion.
You want to take that one, Teresa?
Yeah. Well, we are absolute advocates that if you want to seek a second opinion, absolutely, because it's your life. You're not dealing with a broken foot. We try to facilitate that if it's possible. Sometimes we will do that. You should not feel guilty about asking a second opinion, especially when you're dealing with a disease like gastric cancer. So from a patient perspective and from the work that we do, I say if you're feeling that strongly, you should do that.
I had 3 opinions before I finally settled, so you're your own, even though you feel like death, you are still your own best advocate, so you have to advocate for yourself.
Can I ask one final question?
I think there's also a comment in terms of surgery, so I think, Natalie, you want to take that comment?
Yeah, so I would echo what Teresa just said. And this is a complex cancer. There are a lot of moving pieces. There's chemo, there's radiation, there's stage, there's lymph nodes, there's the type of surgery. All of us in North America are not going to be high volume surgeons by Asian standards. A high volume surgeon by Asian standards would be something like 300 to 700 cases a year. We have 300 to 700 cases a year in all of Ontario. So everyone needs help. We all sit in multidisciplinary tumor boards, and we all work together with medical oncologists. And I don't think you want to be sitting with someone who says, wow, this is an interesting case. I haven't seen one of these in years. That may not be where you want to be. And if you say, I'd like a second opinion, anyone who's treating a complex cancer like this, they recognize the complexity of it, and they will say, absolutely, this is complex. Here's my colleague's card. I'll set you up with them. And if they don't say that, they may not recognize the complexity of what they're dealing with, and that may not be where you want to be.
And I actually just want to echo those very, very similar thoughts. If a patient even has the sense that they were wondering about seeing someone else, then I actually strongly encourage it. Because just even for their own peace of mind of being able to speak to multiple people, and they might see someone else and hear the exact same thing, and that might make them feel more confident and yeah, okay, well, I'm hearing from multiple people that this is the direction that is probably the best for me. So that often even just provides some reassurance. And I mean, as Dr. Coburn said, like, we shouldn't be offended by that. We should be encouraged by patients being their own advocates. And I think you want that kind of support from the care providers that you're working with. And I'm not offended. I strongly encourage it. I think it's good I really like these types of groups where patients are saying, how can we best learn more about our diseases? I think being proactive is very important.
Yeah, some centers won't give a second opinion, but we all encourage if patients need to see another oncologist or a surgeon for a second opinion, we strongly advocate for that.
So there are some it's resources, right? So there are a lot of times where you can't just say, okay, I'm going to go to Sunnybrook, and then I'm going to go to St. Mike's, and then I'm going to go to UHN. But you may say, okay, was my case discussed in a multidisciplinary tumor board? Who was there? And so we would say, well, it was discussed in multidisciplinary tumor board. There were 4 surgeons that looked at your films. There were 5 medical oncologists and 2 radiation oncologists, and this is how the whole panel felt. And that's another way of getting a second opinion without having to book another appointment, go to another hospital, set up another set of
delay treatment.
Delay
treatment. That's only the biggest concern.
Yeah.
And
So that's another way to get a second opinion.
Because time is of the essence. With our disease, time is of the essence, and you can't wait a long time to go see somebody. I tell the people that I mentor that I was a discussion of many tumor boards, and you want your information out there as much as you possibly can get because you don't know where that cure is going to come from. So if I could have numerous doctors looking at my file, great, that's what I did. But with us, it's harder because we have to make sure we have the okay from our insurance before we get the second opinions. And like I said in my speech, I could care less. I wanted to go wherever I had to go to get the answer. But we have referrals and all kinds of stuff. And some people in the United States can't get another opinion because their insurance won't allow them to. And that's all.
And so I just wanted to reiterate that that is one of the things that is one of our key mission goals at My Gut Feeling is we often, you know, as I said, we often help patients who are struggling with that, you know, the question of, well, I don't want to upset my oncologist or this, and we always tell them, and we say it to everybody, if that's how you feel, then you should work towards that because, as Melanie said, we have to be our own best advocates. It's the only way that you'll move forward.
And we do the same with DDF. I've even gotten approved through some patients. I've been put on their HIPAA agreement so that I could speak in their behalf because they're so ill, they can't even comprehend what's going on, but they need the second opinion. So I was the liaison. And my surgeon thanked me. He said, thank you for being a patient advocate and navigator. He said, because people are so ill, they can't navigate their way through this journey without someone like you that's been through it, or someone like you that knows, you know Canada, we know the United States, so we actually help. We know what hospitals are doing what, so we help them get in the clinical studies or do whatever. But you are still your own best advocate.
So I think that sort of ends the program, but we do have one last little thing that we would like to sort of talk about.
Drop the mic, that's it.
So
end of the show, we're dropping the mic.
Yeah. So, first of all, thank you to all of you for being here. Thank you to those online who have stayed with us through, well, we're only 25 minutes over, so we'll be probably about another 5 or 10 minutes. We, of course, could not have done this without many, many people. First and foremost, we wanted to thank our sponsors, our title sponsor, Lilly, our hosting sponsor, St. Michael's, our silver sponsor, Taiho, GSM is our bronze sponsor, and our product sponsors again, Love the Good Fats, Nestle Health Science, and David's Tea.
We also wanted to thank our wonderful volunteers who stuck with us both yesterday and today. It was a big setup for an event like this. So our volunteers are Sky, Tristan, Andrea, Donna, Maria, Joe, Tina, Josie, Matthew, and Christian.
So could you all stand up? I want you all, please stand up. We also wanted to thank our team. So that's Stephanie, who was our coordinator, our event coordinator, and basically saved our lives. And probably my relationship too. Jemica, who's just been at social media for the last 3 months. Nick, who's been our phenomenal photographer today. Daniel, who did all our PR work, and EventStream, who's kind of made us look really great. So we really thank them. We thank the speakers who, every year I'm so amazed by the people that want to be part of this. So we really do thank you. And our panelists, Melissa, Dr. Brar, Dr. Natalie Coburn, and Lena. Our board members, Emma, who was at the, who was trying to sell things, and Ramin, and of course, all the patients, survivors, caregivers, and healthcare professionals who came here today to learn from each other. We do have a couple of more things. Sorry. So in your bags, you will have received little keychains. So just have them with you for a few seconds. So And if we could bring the house lights down, but before we do that, I wanted to let everyone know that this coming year, we are having our inaugural fundraising gala. So we ask that everyone saves the date, Friday, May 8th, 2020, and it's going to be at Bankers Hall, 1 King West in Toronto. So save that date, Friday, May 8th, and we may call upon you for some volunteer work. So that's... So the power of periwinkle. So when we first started this in 2016, we wanted to have, we know that November is Stomach Cancer Awareness Month, but we wanted one day that we could make as our own. And so we decided, all right, let's just say the end of the month is going to be Stomach Cancer Awareness Day here in Canada. We were lucky enough that year we just did buttons and people took pictures, and it's been recognized since 2016 on Health Canada's calendar of health promotion days. In 2017, our national awareness campaign started, and 6 cities across Canada lit up. We were thrilled with that. In 2018, 9 cities in Canada light up, and 1 city in the US. And now, so that was last year, and now we have, so that's 13 from coast to coast, and one that's not even on there, which is Winnipeg, Manitoba, which came in, just emailed us and said that they would be lighting up tonight. And in some of those cities, there's 2 different landmarks that are lighting up. And some of these cities lit up without us even asking. So the fact that people are starting to recognize that this is a disease that needs to be talked about and needs funding and research is so important to all of us. So what we're going to do, so here in Toronto, we're lighting up the Toronto sign, which is about 2 blocks away in Nathan Phillips Square. Those of you who want to join us, we'll be walking over in about 10-15 minutes, and we'll be taking some pictures. Throughout the country, all these cities will be lighting up from dusk till like midnight. Some of them have been lit up all day. Some of them lit up yesterday. So with the key lights, we want everyone to stand.
And can we dim the lights?
Is there any way that we can dim the lights? So we want everyone to stand. And this is for those of us that are patients,
survivors,
and for those that have passed, to all the warriors and their caretakers and those that are part of our teams. This is the power of periwinkle. Thank you, everyone.